Okay, so first we have Dr. Carolyn Greene, who is an associate professor in the criminal justice program at Athabasca University. She completed her PhD in criminology at the University of Toronto. Currently, her research is focused on 3 SSHRC-funded studies examining immigrant perceptions of police in Canada, experiences of invasive policing practices in Toronto, and community perceptions of and experiences with harm reduction services in Edmonton, Calgary, and Lethbridge. Her research interests are broadly focused within policing, homelessness, drugs, youth justice, and operations policy.
Thanks very much. I will get started and jump right into this. I don't have a whole lot of time, and I want to make sure we have lots of time at the end to really go through people's questions, because I think that's probably one of the most important pieces here is engaging with everyone. So I love the title of the talk today, Beyond Not in My Backyard. I feel like it's so fitting, really, because this crisis has been in our backyards and front yards for some time. And a lot of people have been sort of trying to deny that fact or deny that there are needed responses to it. And so I'm going to quickly sort of set the stage for how we got to this point. Beginning in the 1990s, we see the introduction of opiates as a form of pain medication, and these are overprescribed beginning in the 1990s. And over time, this creates a scenario where we have increased the number of individuals using a highly addictive pain medication, which contributed to substance use disorders over time, significant numbers of these. And what happened then was a crackdown on access to these pain medications. And so a number of people who became dependent on access to these medications had to then turn to illicit forms of opiates such as heroin. Not everybody, but some folks. So this was done to address that need for the medication. So over time, we see this growth in substance use disorder in this area. And more recently, the introduction of synthetic opiates, which they're highly lethal and are responsible for significant numbers of overdoses and overdose deaths. And they have tainted drug supplies across Canada and the US in particular. And so not only now are people at risk of coming into contact with lethal amounts of fentanyl through an opiate, but it is also present in, for example, methamphetamines. So those not even intending to take an opiate may be exposed to these drugs and be at risk of experiencing an overdose. And so when we talk about the toxic drug emergency, largely what we're talking about now is the introduction of synthetic opiates and their presence in a vast number of drugs in the drug supply. And that, could be counterfeit pills that are made, you name it, fentanyl is probably present. So that's sort of the context. We can talk more if anyone has questions about that. I'm going to really kind of whip through it. There's a lot more to this, obviously, but that's kind of the Coles Notes version. Now, what's happened with this is we've got high rates of substance use disorder. We've got increasing numbers of overdose deaths. We have also significant social impacts, unemployment, higher rates of crime, higher rates of disability, folks dropping out of school, families being torn apart. All of these things are associated with this crisis. So teasing those things apart, you can't really do that. These things are intimately connected. Now, Canada and the US are sort of the hotbed for this right now. We have really experienced the sort of the most severe outcomes in this regard. No communities have been immune to this, but rural communities have actually disproportionately felt or disproportionately been impacted by this drug poisoning crisis. And unfortunately, not a lot of research has been done with rural communities going forward. As a result of this, much of the research we have is based on initiatives that were started in urban centers. So I will come back to this in a few minutes, but I think it's really important to keep in mind that we have really dropped the ball in terms of gathering the needed data and doing the research with communities, rural and remote, to ensure that we are doing and meeting the needs of those communities. Now, to go back to the overdose deaths, I really want to bring this home for everyone and just point out how devastating this crisis has been. If we look at our prairie provinces, Saskatchewan, more than one person every day in 2022 died from a drug overdose. In Alberta, between 2019 and 2022, there has been a 139% increase in the number of people dying from opioid poisoning. Manitoba, over that same time period, 177% increase in the number of people dying from drug poisoning. So this is a problem that is not going away, and it really does need to be looked at. Now, this is not an easy solve. This is a crisis that is going to require a number of tools. Harm reduction is one of those tools. There are other tools. I'm going to, as a criminologist, obviously, I'm going to begin with criminal justice intervention. This is something historically that we in Canada and, especially in the US, have tried. Criminal justice intervention does not work when we are talking about drug use. This is something that is highly problematic. It doesn't solve the problem. Certainly, there may be some aspect of criminal justice intervention that can be a part of the tool in terms of drug trafficking. I'm not suggesting that, criminal justice agencies, poof, they're gone. But in terms of dealing with people's substance use and substance use disorders, there is no evidence to suggest that criminal justice intervention is going to help solve that problem or provide someone with a way out of their drug use. If anyone has questions and wants to talk more, I will leave that to the end. I could talk for days about that, but I will just, simply say criminal justice intervention is not the answer here. There are a number of other things that we can do as communities, as cities, as, with our governments, as voters, thinking about those tools, ensuring that we have adequate space for treatment, absolutely a very important piece of this puzzle. It's not the only piece of the puzzle, however, because not everybody is going to be ready to access those kinds of resources. And so, we want to think broadly about how we are going to respond as communities. I'll jump right into harm reduction and broadly speaking, and I hope not to touch too much on what Kate and Kathryn are going to talk about, because they have a wealth of information to share with everyone that I think is going to be, it's extremely important. So just kind of opening the door for them around harm reduction, what I would say is that we have a long history in Canada with successful harm reduction operations. We had a safe consumption site in operation in 2003, and it has been operating since. So, safe consumption services are just one piece of that. Harm reduction can provide clean drug supplies, access to naloxone, a variety of things that reduce the harms associated with drug use, which is critically important if we want to, get to a point where we are reducing burdens on healthcare systems, where we are helping people to get to places where they are ready to access treatment. So those are the sorts of things to keep in mind. You know, there's much more to harm reduction. I'll leave to Kate and Kathryn to sort of to dig into around what those programs look like. But, you know, I think pointing out, you know, in Alberta, for example, in one of our safe consumption sites, researchers looked at responses to overdoses on site, and they did a cost benefit analysis. And what they found in this research was that for every overdose attended to within the safe consumption service, it saved the healthcare system in Alberta $1,500. And they were responding, it also then did not require the access of an ambulance for the most part. So you can imagine in a place like Calgary, where every month there are 420 times where an ambulance is not available for an emergency, that sort of service and access to that sort of service is critically important. Now, going back to that research piece, very little research has been done on what has been happening in rural communities. The research that we do have on harm reduction is coming out of urban centers. And while it has shown us incredibly positive results in terms of reducing, negative health outcomes, for example, reduced disease transmission, those sorts of things, we don't have those pieces for rural communities. What we do know about rural communities is that there are significant barriers for individuals suffering from substance use, in particular opioid use disorder, in accessing services, primarily because there's very few to no services available close by. Transportation to and from clinics can be problematic. There are challenges when you're in a smaller community with issues around privacy. So that, I think, you know, that's where that issue of stigma, I think, is really important, and talking about that. The other issue is, this is off the cuff here, but I think, you know, when we look at rural communities, there is a tendency in public perception research that folks hold sort of more punitive views around crime, around drug use, and those kinds of things. And so when you have folks that hold these more punitive views, it can be kind of scary to introduce new ideas and new ways to deal with drug use. And so, you know, in that way, probably, you know, the issue around attaining that broad public support in those communities, you know, there may be some pieces there around education that we could talk about, and outreach that might be pretty important. But I think really, yeah, I think I'll leave it there, because I could probably talk forever. And I know Kate and Kathryn really have important, you know, work that they're doing that they can share with everyone. But yeah, I mean, this problem really it's in our backyards, it's in our front yards, and we need to use all the tools we have available to us to reduce the harms associated with drug use and the harms that our communities are facing as a result of the drug use. So yes, thank you. And I'm happy to answer any questions at the end.
Great, thanks, Carolyn. That was an excellent introduction. Did we want to have any questions to that presentation?
No, I think we'll have them at the end unless somebody has a technical question.
Okay, then. Lorelei, would you introduce our next presenters?
Yeah, so I'd like to introduce you all to Kate Hodgson. She's a settler of mixed European ancestry and has lived and worked as a rural nurse in the field of substance use and harm reduction since 2010. She's currently working as a nurse practitioner at the North Island Medical Clinic in Powell River, BC, and as a nurse educator at Lift Community Services of qathet. As a research fellow with the BC Centre on Substance Use, Kate focuses on qualitative research with a special interest on patient-identified treatment goals and the accessibility of opioid agonist therapy in rural settings. And then I'd also like to introduce Kathryn Colby, who lives in a small cooperative with friends, her partner and baby in the wooded paradise of Klahamen in Qathet, and is a boiling tea kettle of enthusiasm for all things that make person-centered equity happen in a community. She is a manager of community development at Lift Community Services and has been coordinating regional community overdose solutions since 2018. Community development liaises with local and provincial leaders around large-scale social issues such as the overdose crisis, trans and gender diverse supports, housing, homelessness, sex work, restorative justice, and anti-racism. Kathryn holds a master's degree in the humanitarian discipline of human security and peace building. Additionally, she's been honored to have built 20 plus years in the nonprofit and social services, social work sectors, with a special interest in working alongside people coping with complex mental health, substance use, and homelessness. So please welcome Kate and Kathryn.
Great. Okay. I'm going to start us all off. As you heard from Lorelei, my name is Kathryn. It's an honor to be here with all of you focused on this rural issue. This is, to me, a very deep issue that we could talk about forever. So we're just going to do some high level chatting today. And then I'm hoping to have some opportunity to reach out to other folks if they want to do more deep work in their own communities. And I'm very nervous today because of all of you being here. So I'm just going to say, this is one of our peers. His name is Cosmo. We have permission to share this. And this is the mural and logo that he created for our original overdose prevention site that you'll hear a little bit about later, but it started as a tiny brick code trailer in the middle of a field. Next slide, please. Of course, we humbly and respectfully acknowledge the land on which we live, work, and play is the traditional stolen and occupied territories of the Tla'amin, the Klahoos, and the Hamalko First Nations. And I'm calling in from Tla'amin territory today. Kate, where are you calling in from?
I'm calling in from Hamalko territory.
Oh, you're in Hamalko, beautiful. Oh, you're in Quadra. Okay, yes, beautiful. Disclosures, we have no financial disclosures other than the fact that we are lucky to do this for a living through our nonprofit lead, which is Lift Community Services. So just a quick kind of talking about stigma-free language. So things to avoid: drug abuse, misuse, problematic substance use, addicted, addict, etc. We're asking folks to really focus on really positive and real neutral kind of health-based language. So things like this: impacted by or coping with a substance use or substance use disorder, engages in substance use, has lived experience with substance use, etc. And I just want to say that language really has the power to kind of elevate the conversation. When we unlearn stigma through language, our actions are more powerful and really grounded in justice. And that said, we ask you to please speak freely in ways that you feel comfortable with. This is a place of learning, and we carry no judgments around how people express themselves. Part of working in the rural context is that we all deserve to be met where we are in our own stages of understanding and learning as well. And this learning is to help us all move into a more justice-oriented space together. So please don't feel ashamed if you feel like you make a mistake around language. We're all here to learn, and perfection is frankly like a white supremacist value, and there's no place for that in this justice work. Okay, next slide, please. So thank you, Kate, for taking the primary themes from all of the generous responses received from all of you. We recognize through this alone how closely linked our struggles are and how much we have to share and learn from each other, specifically around themes of public resistance, poverty, intersections of marginalizations. And we ask that everyone be gentle with themselves today so that we're able to move forward in the context of the poison drug supply together. And please know that your work is not only needed, but it's important, and it's more than worthwhile. And it's hard to feel that way sometimes. Okay, next.
Great, thanks. Yeah, thanks, Kathryn, for getting us started. There's lots, thank you all for joining. There's lots of names I don't recognize because we're presenting outside of BC. So this is really a great time to see more of you across the country doing the similar work. So to get us started, I would like to introduce our rural community that we live in. So it is qathet. It's also known as Powell River. That's what you see in the BC Coroner's Report. But qathet is likely not dissimilar to the communities that you all represent on the call. So qathet is a remote community and it's located on the northern region of the Sunshine Coast, and it has a population of about 20,000 people. It also spans about 5,000 square kilometers, so it's quite dispersed. It is considered remote because it's accessible only by plane or ferry. And it also includes some small inhabited Gulf islands. So we can cross over from Comox or from the lower mainland and then reach some of the smaller islands as well. And as to Carolyn's point, is that like many other rural communities, qathet is disproportionately impacted by toxic drug deaths. And what this means is that compared to other larger communities in the region, qathet consistently has a higher per capita drug death rate. For example, one statistic we have here that in between January and August 2022, the per capita drug death rate was 100.1 per 100,000. And that was in fact more than double that of the overall Vancouver coastal health region, which at the time was 47 per 100,000. So this is like actually quite tragic and heavy statistics and is really felt amongst our community. Similar to other rural communities, like Carolyn was saying, is that qathet has a limited number of harm reduction services. Yes, we're going to present our enthusiasm in the programs that we've developed, but there's still limitations. And some of those is that all our programs are located centrally, which makes it really difficult for people who live in more remote or isolated parts of the region to access services. Next slide. So this is just a little lay of the land. It represents the 5 regional health authorities that operate in BC. And qathet is located in the Vancouver Coastal Health Authority. And right where that arrow is, just north of Gibson's, south of Bella Coola, Texada, Savory, and then you cross over to Comox. So it's considered the Sunshine Coast. Next slide, please. So this slide is from last year, but it's a bit of a hot spot to demonstrate that toxic drug death rates are really impact the rural areas of BC, our province. So as you can see, the darker features of this map are located in the north, the interior, and at some points, the northern Vancouver Island and northern coastal region. So qathet is located in the NSCG, and as you can see, it's not in part of the dark red. However, these rates are averaging across these local health areas, and when you start to dig deeper into these regions and really look at some of the specific communities, you do see that death rates for the smaller communities are higher per the entire region. So this really creates confusion as to how some of these statistics are communicated, and it creates challenges for communities to be interpreting this data and not really getting the full picture of how the toxic drug public health emergency is impacting their communities in order to be able to communicate that to stakeholders to get people, rallied together and working towards the same goal. So next slide, please. So the rural paradox. So as Carolyn has alluded to, is that this is really the problem that we're seeking to address at LIFT Community Services and also in terms of our provincial and national level advocacy. So we do know, as the map shows, that rural and remote regions are highly impacted by the toxic drug crisis. Yet the focus continues to be with innovation and implementation science that is focused in urban settings. And oftentimes rural and remote communities don't benefit from some of those programs unless there's a few or multiple champion stakeholders in the communities. Next slide, please. So the next few slides, I'm just going to go over a little bit of what the evidence says or what it means to be operating in like an evidence-based fashion when addressing substance use. So What we do know, and this is, this is layers of research and layers of guidelines that have condensed into one slide. So if you have any questions about this, please ask after the presentation. But what we do know for sure is that opiate agonist treatment is the gold standard treatment for people with opiate use disorder. In fact, people who are not on OAT are twice as likely to die from an opiate overdose from the toxic drug supply compared to people who are not on OAT. So what OAT is, it's a class of medications that we consider methadone, Suboxone or Sublocade, it's also called buprenorphine, and slow-release oral morphine or Qathet. What we also know is that stigma in healthcare prevents people from accessing services. And a large proportion of people who die from an overdose have recent contact, like recent within 3 months or definitely within the first year, a year before their death, that they have contact with a healthcare provider. However, they're not linked to the services that could have prevented their overdose. So we understand that stigma is a driving force of this. And as we work in the field, we need to really demonstrate that everyone, including people who use drugs, have the right to housing, community connection that's free of stigma and judgment, so people can access those services and get the resources that they need. We also know nothing for us without us. This is really Kathryn's tagline. I'm going to let her talk more about it in her parts of the presentation. And then we also know there's lots of debate right now, but we do know that safe supply does prevent death, and it does not lead to any additional opioid drug poisoning. Safe supply is people accessing the right drug at the right time in the right place for the right route that they need. And what we do know is that it is fentanyl, not prescribed safe supply medications, that are driving drug-related deaths. Next slide, please. So in addressing stigma and looking at the full continuum of substance use care, we work on the assumption that substance use in and of itself is not inherently harmful. So we know this. We know that drug use is embedded in all social processes. It's been in all civilizations since the dawn of time. And the only reason why drug use is criminalized and prohibited today is because of the Opium Act that came into place in Canada in 1908 and effectively criminalized all people that use drugs and really started the war on drugs. In fact, before 1908, people had access to heroin tinctures. They gave it to their child. They used it to treat diarrhea and respiratory problems. And, Thomas de Quincey wrote about having heroin in his pocket that just solved all his problems, and he would just take it and, no big deal. So really this concept of that drugs are bad and people who use drugs are bad is a new concept. And not all substance use is harmful. I think that's something that we forget. And it is a driver of stigma and thinking that all people who use drugs are bad. But in fact, harmful substance use is really only a very small proportion of the substance use that occurs. And people who experience harm from their substance use is actually a small proportion of all people who use drugs. So there's value in using this continuum. And I've borrowed this continuum. It's in the FNHA OUD toolkit that's available online, but really thinking about, people who access legal medication as well, legal substances as well, like alcohol, tobacco, and cannabis, or use it for medicinal purposes. Next slide, please. So this is an old diagram, but this is from the BC CSU. So this is when we're talking about some of the interventions, especially some of the medical pharmaceutical interventions. This is really what we're talking about. So we have opiate agonist treatment that's in the center of this depiction. So that's Suboxone, methadone, slow release oral morphine. And then of course we want to offer all psychosocial wraparound treatment supports. And it's really plus or minus inpatient residential treatment. The other end of the spectrum is more intense. So often that means requiring more nursing or workforce, people to be involved in someone's care, and that's specialist-led interventions. So at this point, this really includes things like fentanyl patch, things like injectable opiate agonist treatment, what someone requires when they need to step up their care. On the other end of the treatment, and this is really thinking in more of like a pharmacological way, is withdrawal management alone. So I'm going to talk a bit more in the next slide, but we do not recommend withdrawal management without any opiate agonist treatment. And that includes in places like detox or in residential treatment. So those are considered lower intensity. And then of course we have harm reduction throughout the spectrum. And we'll talk more about that too. Okay, next slide, please. So I do recognize that there was lots of comments around withdrawal management or detox and treatment, also known as like inpatient or residential treatment in the Athabasca survey. So lots of folks commented on it. And sometimes this next bit of information I'm going to provide, it takes a little bit for people to process, but Carolyn did kind of introduce it. And please, if you have any questions about this after the presentation, I'm happy to talk more about it. But it's that really recognizing and thinking about that withdrawal management alone is not recommended. So withdrawal, when someone detoxes, their opioid tolerance is reduced and they're at increased risk of death. And so this is true for people who are exiting prison or hospital or reducing their drug use. We also recognize that although residential treatment is valuable and provides a safe place for people to learn new skills and to have some respite from substance use and poverty, is that treatment centers have limitations. So the care they provide is not monitored very closely. At least treatment centers in BC do not have to report outcomes like other programs. And we actually don't know the risks of replacing on someone when they access treatment and stop using substances, and then they leave treatment and are, exposed to, the toxic drug supply again in the forms of like a relapse. So this really hasn't been evaluated. And oftentimes treatment centers don't allow OAT. So it's just about thinking critically around some of the things, we've kind of, the way we've done it. And treatment and healing can occur at home in community when people have access to things like secure housing, wraparound supports, and replacement therapy. So it's really about giving people the autonomy and the right to choose when they want to go to treatment and if that's the right step for them. Next slide, please. So this is the last slide, just around some background. So, what are we doing then? What is really harm reduction? So we know that drug use in and of itself is not inherently harmful. So yes, we're reducing some of the harms that are related to substance use and intersections of poverty and intersection of criminalization. But we know that the main driver of drug-related harms is really oppressive policy that effectively criminalizes people who use drugs and creates this disparity of social structural vulnerabilities amongst this population. So what we're doing with harm reduction is really finding ways to mitigate some of these harms from drug policy and drug laws and to improve people's lives. Although it is one thing to provide harm reduction services to improve health outcomes, but if we're not addressing the overall disparities and we're not addressing some of these oppressive policies, which, maybe if there's someone from the federal government here, is really means an end to the CDSA, the Controlled Drugs and Substances Act. But if we're not doing all those things together, like Carolyn alluded to, like a multi-pronged approach, then we're not really going to get to the crux of the problem. Yeah, go ahead, Kathryn.
Thank you so much, Kate. So we know that travel burden, as well as a number of other things, contribute to rural spaces being so deeply affected by the toxic drug supply. And there are multiple challenges in rural environments to anyone seeking services. We know that rural substance use looks very different compared to urban spaces, such as a limited supply of illicit substances that are more frequently cut with unknown substances. And that people who use drugs, especially in our region, prefer to buy in bulk where possible, which excludes them from the limited decriminalization of personal possession in British Columbia. Additionally, people in smaller communities are also very deeply entwined with the general population, as well as a more marginalized drug-using population. So people really stand in both worlds when they use drugs in rural communities due to this interdependence and intertwined lives that we share as a smaller population. So it makes seeking help or talking openly about substance use or even talking to doctors about these things seemingly high risk, because stigma around substance use can compromise people's employment or other sexual relationships in their lives. As you can see here, these are some of our published studies that we commissioned for our region that really speak to the surveillance and stigma at the heart of people's crises. Next slide, please, Carol. So we are, of course, as Kate mentioned, a region that is only accessible by boat or by plane. And therefore, our supply of illicit substances is kind of just like what we get. Rurality is a major determinant of health. There are multiple reasons that people use drugs or to travel. They must travel further distances to access harm reduction services. So these are from some of the qualitative interviews that were done by the BC Center on Substance Use. So without a vehicle, you're pretty much screwed because not all of us can afford the gas. And we had a truck, and when the truck died, we had to walk, we had to hitchhike into town. So this is folks that want to access services, want to be with other substance users, and want to hold space where they belong that often just cannot get to centralized services. Okay, next slide, please. So the stigma or NIMBYism, so not in my backyard-ism, which is so classic in qathet. You know, we deal with angry neighbors a lot, particularly some louder folks that love to get behind the keyboard and say really awful things about people who use substances on Facebook and other social media. And often what they say is, well, you know, I think that people deserve these services. It's just, why do they have to be in my neighborhood? Which is quite funny, because when you think of a very tiny community, it's like the centralized services are the centralized services, and they're kind of in everyone's backyard. So, of course, the surveillance of people who use drugs. Profiling or surveillance of people who may be more visible in substance use due to poverty. And surveillance culture in a rural context can look like dash cams, wildlife cameras, and private surveillance cameras. We have a zine produced by the Substance User Society here, where they have taken clippings of people posting people's photographs, and many of whom are not even using substances. They're just assuming that all people skulking around or wanting to create crime are using drugs. There's a deep resistance to harm reduction. People are concerned that people will be attracted to those places, or there will be harm reduction supply litter around. There's always the moral debate. People choose to use drugs, or bad people use drugs. There's a lack of education around substance use and the reasons that people use drugs. And there's stigma towards treatments and programs for people who use drugs. So unless it's residential treatment where it's abstinence-based or punitive, people are not very accepting of that, despite good evidence otherwise. And, you know, drug use is stigmatized and it others people as outside of the community and or racialized people that are moving here. The homeless services of British Columbia came recently for a homeless count in our region, and they jokingly called it the magic school bus. Every rural community has a magic school bus of people coming from the city that are being attracted to our services that we're opening. There's not a lot of critical thought around intersectionality or mental health concerns. And, you know, frankly, needles can be scary, but what is the actual evidence around that? Well, the evidence of picking up a used needle is that under 1% of risk of bloodborne diseases. And then, of course, the worst that can happen is you get a staph infection from accidental pricks. Next slide, please. So part of being a nationally recognized rural and remote community means that we inherently have shortages of labor, right? So there's rural healthcare shortages everywhere. There's a lack of harm reduction specialists, and harm reduction is not seen as mainstream. It's seen as a niche sort of practice. Providers are unwilling to provide harm reduction services. Of course, there's the limited knowledge of training outside of large urban centers. And then there's also a fear of making a mistake or being outed by peers. And then, of course, it's difficult to assess the level of need because there's so few resources or access points or pathways to care for folks. I think I had another little thing about this. Oh, yeah. It just means, frankly, that people are not available to assist people when that window is open, where they're feeling like contemplative and wanting to move forward in accessing better services for their substance use. Next slide, please. Okay, just going to switch gears here and talk a little bit about the rural community engagement that we do here. So one thing about living and working in a rural environment, especially as a former urbanized outsider, who moved to this area, it's to ensure that any approach that you take in your rural and remote environment doesn't feel colonizing to your community. And taking, of course, a similar approach for indigenized spaces, we recommend really listening to the community, which means that if you're listening to people who've been in the community for a long time, are living or have lived experience, are families or local leaders, you really are listening to the experts. We have this idea of expertise being outside of our community, but really we use kind of assets-based community development, which means everyone that we have in our community are the right people, and everything that we have here it's the right skills. So rural community engagement is also interesting when you factor in that so many folks have dual roles and relationships, and people are much more interdependent and intertwined than in larger centers. As such, it actually can take a lot of courage to speak out and up and create a safe and confidential space. It's inherent. It's so important to be able to create confidential spaces. I'll talk about our CAT meetings in a moment, but they are confidential. If you want to move forward together, this is an incredibly important thing, is in building that trust and confidentiality. Next slide, please. Okay, so technically our local stakeholders are everyone that lives here, but we focus on community leaders, people with lived and living experience with substance use and their families to guide the work that is most needed. So this could include nurses, doctors, paramedics, local civil government officials, nonprofit and health authority leadership, in addition to coordinated access to folks within both PLOM and governance and health. It's incredibly important to champion harm reduction as an essential service among all healthcare providers. And so we can talk about what the community action team is able to do that. And this is a big part of how we're able to take action in our community, is that we're addressing a common problem. We develop a full continuum of care to the best extent locally, and then we want to be able to create multiple pathways to addressing the poison drug supply while providing education and developing community readiness through these processes. Next slide, please. Okay, so community action teams are kind of an interesting thing in British Columbia. So what happened was in late 2017, which was about a year and a half after the public declaration of the health emergency related to the poison drug supply in BC, the Ministry of Mental Health and Substance Use, formerly the Mental Health and, is it still the Ministry of Mental Health and Addictions, Kate? Unbelievable. Anyways, hopefully their language will catch up soon. Created the Overdose Emergency Response Center, we call it the OERC, and it created a pathway for communities to mobilize their own resources to address things locally. The OERC piloted community action teams with 17 communities with high per capita rates of overdose death related to the crisis. And we were in this group, sadly, and we were up and running in 2018 as the funding came through. So the goals of community action teams were to develop an action-oriented response that's inclusive of all community partners, create an action plan to address the specific needs of Powell River, which we soon learned were shared needs across rural and remote communities, and to highlight local innovations and identify and escalate any barriers to service. So basically what we had through the overdose emergency response was like a direct line to the Ministry of Mental Health and Addictions. So we were able to say things like, how do we get detox beds in our community? Or how do we ascertain what is available for resources for people that want to go to residential treatment? And then they were able to come back with a rapid answer and a pathway to these issues that people were coming up systemically in their work. Next, please. So Oh, I forgot to mention that, yeah, until last year, we were second highest overdose rates in the province per capita, but now we vacillate in the top 14 because other rural areas are more heavily impacted than they were before. So these are the principles of the community action team. Of course, collaboration, nothing about us without us. Consensus, consult experts. So when we say consult experts, it's people within our community and then outside of our community. That we design everything thoughtfully for far-reaching and shareable impact. So anything that we do here in the region of qathet, we want to be able to share freely and have replicated in other rural and remote spaces. One thing that we really recommend is that when you're developing services to meet needs, that people who the service is going to be designed for are the people that design the service. So substance users designed the overdose prevention site. They helped us design IO clinic. Kate will talk more about that. And frankly, we're in a state of emergency and substance users cannot wait. We cannot wait until the kind of wheels of bureaucracy are turning enough for us to make real change for people on the ground. Our job is to immediately put services in place to stop the bleed, let's say, and then move on to like the whole body. Like this is sort of what we're coming to this work as, is emergency and emergent collaborators. So the CAT priorities are simple. We just cannot wait for action. We must take action now. And as a result, all non-health authority harm reduction and substance use services in our community have been rapidly developed by the community action team through LIFT thanks to the stewardship of LIFT Community Services and their vision as the nonprofit lead for the qathet CAT. And as Carolyn mentioned earlier, we quickly realized the need for more research and education pieces to help normalize drug use and to also inform how we want to move forward in a sustainable way. All right, go ahead, Kate.
All right, so this part is a very fun part of the presentation for Kathryn and I. We're going to do like rapid fire talk about all the programs we've developed. So get ready. So next slide. So first off, one great thing about LIFT being the operating nonprofit for a lot of these programs, that LIFT's values really align with a lot of the harm reduction work we do. And so, I mean, if there's communities who have similar types of organizations who are really trying to get programs off the ground, is around finding those values that bring people together, that include everyone, so inclusive. So growth is that some of this growth means about bringing people alongside us and helping educate and really bring people along, and also support the staff who work at our organization, and then of course community members and the people we serve, and then being community focused. So just really putting the needs of the people we serve and the needs of qathet first. Next slide, please. So one of the first programs that we developed, and all of these programs were developed from the community action team. So thinking about funding in your own community is really going to the ministries and the government that funnel funding for the toxic drug supply. There's quite a lot out there. There's also federal grants if you don't have your pulse on provincially or locally, but this was really the first program we did. It was right at the outset of the public health emergency, and it was naloxone training. So this was a time when naloxone training was still a bit novel. Not a lot of people know about it. And what we did is we had some champions from the community action team who was a nurse, a paramedic, and an outreach worker. And they focused on just doing naloxone training at all community events within that like first couple years of the emergency. So this normalizes the presence of naloxone. It accesses a group of people that maybe wouldn't normally have access to naloxone education. And then we also expanded it to doing outreach trainings at local businesses. And surprisingly, many local businesses were really wanting to have it because people, organizations and companies like construction companies, where there's an inkling that folks who may work for these companies are at higher risk. Nobody wants people dying at their on their crews or people they know. So we did do outreach to construction companies, to the library where a lot of folks hang out, to the rec center, and even municipal government offices to try and get everyone trained up on naloxone and also do some basic harm reduction education. Next slide, please. So our inaugural overdose prevention site. So Kathet's overdose prevention site was a Brickco trailer. It had like 2 or 3 booths. It had a garden. It was in the field. Like, it was very rural. It was very simple. It was almost completely peer led. We had a paramedic who was a coordinator. But yeah, it started super small in June of 2019, and then now we've expanded. And now the overdose prevention site is co-located in a community resource center, which is also very cool for people to be able to access lots of supports, and also just like normalizing substance use. And now we have over 1,000 unique visits. So that's 1,000 individual people who are accessing the site per month. So that went from like 35 unique visits in 2019 to 2023 to 1,000. So we have effectively recruited lots of people in the region that use substances to use witness consumption. So truly build it and people will come. And then we've recently gone from an honorarium model of paying peers honorarium. If you have more questions about that, we can answer them. And we've just recently onboarded all peers as staff. So now all of the peer workers are considered support workers and equivalent to all other staff within our organization. Okay, next slide, please. SUSTAIN. So SUSTAIN it stands for Substance User Society Teaching Advocacy Instead of Neglect, and it is our peer-led advocacy organization. And its real purpose is to teach others and to get people who use substances together over a common goal. And what the CAT has done in other organizations and other research teams is really position SUSTAIN as an expert in the field. So SUSTAIN is consulted when programs are developed on different questions. SUSTAIN is paid to provide this expertise, and it's really building momentum and getting recognized by other peer-led groups in places like the downtown east side, like Dolph. So there's this like natural networking that's happening too that's really cool. Next slide, please. So prescribed safer supply. So we, I do have to say that every program we started, there were naysayers. There were naysayers even within the fields that we had. So there was at least one person who told us, you can't do this, or that doesn't need it, or something to that effect. But in 2000, we opened our injectable opiate agonist treatment clinic in 2021 or 2022. I can't remember.
2021.
2021. Okay. And so prior to the opening of our prescribed safer supply clinic, this is when we had very high rates of drug deaths. And it started as an injectable IOT clinic. But you know what? We found out that no one really liked injectable hydromorphone. So we had to pivot very quickly. And so at this point, we're offering hydromorphone tablets. People can crush up and inject them, can crush and insufflate them, are also known as snorting them, and people can take them orally. Hydromorphone doesn't smoke well. If it did smoke well, we would encourage people to also smoke it if that was their route of choice. But we are looking for other smokable options down the road. And we also started fentanyl patch. And then of course, we also provide people their oral oat because we know it's so effective. So for us, we serve up to 25 people. And certainly there are people that we have prevented death in by providing prescribed safer supply. And we work very closely with other care teams, like community pharmacies, and we really are filling some of the gaps. So next steps for us, we're looking to get diacetylmorphine, which is also known as DAM, which the ministry has also been kind of like talking about for a very long time. And then we're also looking about at Fentora and then fentanyl powder to be able to smoke as well. Next slide. So the last, I think it's the last one, but it's just around, we already talked a lot about like just the importance of research initiatives. So it brings attention, it brings funding, it brings like big, like provincial and national scale research organizations and PIs to your community. So they really get a sense of what's going on. And then it's really all about using that knowledge, being the owners of that knowledge as the small community, and translating the knowledge through media and through different presentations at municipal government to garner some of the traction that you're going to need. So we've worked in collaboration with the BC Centre on Substance Use. That's the team that I've also worked alongside, and I've been able to write a paper, and we really focused on qualitative research. It started as a small group of interviews, and then because of the success of that small group, we've now got a larger pot of funding, and we're going to focus on evaluation of OAT and IOAT in the qathet region. So it also creates like funding opportunity to be able to evaluate our services and get the feedback that we need to improve and create better